A very good morning to all participants of the 4th Emergency Medicine Seminar Series 2022. This will be our week 2 for our series topic Marine Organism, Envenomation and Poisoning. We have 4 distinguished speakers today: Dr. Zainal Abidin from Hospital Tengku Ampuan Hafsa, Malaysia; Dr. Aida Noor Sharini from International Islamic University, Malaysia; Associate Prof. Dr. Satria Trakurisri Chai from Ramati Bodhi Hospital, Mahidol University, Thailand; Prof. Wilfredo Lichuanan from De La Salle University, Philippines. So before we begin our session, I would humbly invite our advisor, Prof. Khaldun, to give a word of view before we start our webinar. Prof. Khaldun.
Assalamualaikum warahmatullahi wabarakatuh. Very good morning to everybody. Thank you for joining us again for our second chapter for the 4th EMSS 2022. We had a very good response from last week's seminar, and we hope to continue this momentum for the coming seminars as well. So I hope everybody had benefited from our previous webinar, and I think more will benefit from our up and coming webinars as well, because there are many issues that is currently going on in the community, in our community, and also in our practices that reflect the importance of the topics that we choose during this 4th EMSS. So I would like to thank our distinguished speakers for today, Dr. Zainal, Dr. Aida, and also our international speakers, Prof. Sataria and also Prof. Likwanan. So I hope this will actually be kind of a standard approach that we use to address the issues, and we share our resources, not just in our own country, but we actually share kind of a common issues in the Asia Pacific region. So that's why we thought that rather than just having our own what we call continuous medical education, because of technology today, as you can see, we can go international reach and also sharing without actually leaving our own country. So that is actually something I think will become a trend, especially during the pandemic, and I think it will be also a trend for future events where we have both face-to-face and also online, or what we call hybrid session. So without further delay, I would like to say thank you also to our committee who has been working very hard these past few months, and it has come to bear fruit with our events for the next for this month. Okay, with that, I thank you and enjoy the session.
Thank you, Prof. Khaldun. All right, so let's begin our day today with Dr. Zainal Abidin. Dr. Zainal Abidin is a consultant emergency physician in Emergency and Trauma Department, Hospital Tengku Ampuan Hafsa, Kuantan, Pahang, Malaysia. He is also the State Head of Service for Emergency and Trauma Services in Pahang, Malaysia. He is currently the Vice President of Malaysian Society of Toxinology, MST, and consultant for Remote Envenomation Consultancy Services, REX. He has special interest in emergency medicine, clinical toxinology, pre-hospital care, and disaster medicine. He is currently involved in pre-hospital thrombolysis project in Pahang. He has conducted several educational programs and life support courses for students, healthcare providers, and the public. Let's welcome Dr. Zainal to present on his presentation on marine animal poisoning.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, the chairperson. Welcome to EMSS Emergency Medicine Symposium for today. Thank you very much, Prof. Khaldun, for inviting me as a speaker for this session. I'll share my slides. Okay, so I'll talk within about half an hour. So at the end of this presentation, we hope that we're able to understand the spectrum and causes of marine animal poisoning. And number two, what are the marine animal poisoning by biotoxin? Specifically, I'll talk specific about a few examples of marine animal poisoning by biotoxin. And at the same time, I'll talk about the clinical approach of management of marine animal poisoning. So marine animal poisoning, we can suspect any person or patient who come to seek treatment after they have eaten seafoods like fish, shellfish, or others. It can appear but maybe immediate or even after a few hours after ingestion of the food. And the marine animal poisoning is a group of acute illness due to ingestion of fish, shellfish, or marine animal that contains toxins or poisons. These toxins or poisons is accumulated toxic compounds that is gained from the environment, or it can also endogenous, in which it is produced by the animal itself from its glands, or it is due to infection or contamination. And it has various symptoms. It can from mild to fatal. For example, gastrointestinal, neurology, and even allergy. It looks like allergy, but it is not allergy. So the causes of illness or food poisoning or marine animal poisoning, it can be various. It can be because of infection in which it is contaminated. That most of the time it is presented with GI symptoms such as bacteria or listeria, or viral like hepatitis A, or parasitic like nematodes or cystodes, and toxic infection like Vibrio cholera. It can also due to intoxication, and then it is caused by toxin such as Ciguatera, shellfish, scambroid, and tetrodotoxin. It can be from the microbial like Staphylococcus aureus or Clostridium botulinum, and chemical like heavy metals. So for this presentation, I'll concentrate on biotoxin. So if you look at the marine poisoning by biotoxin, this chart is just I've summarized all about what I'm going to talk today. Number one is about Ciguatera, in which involves ciguatoxins, and it comes from dinoflagellate. It's a food of the fish, and most of the time it is involved fish. And number two is about tetrodotoxin, in which the toxin is tetrodotoxin. The source is flesh from skin and viscera of the fish, like pufferfish, horseshoe crab. And the third one is about shellfish poisoning, that we have 4 subgroup in which paralytic shellfish poisoning or PSP, number 2 neurotic shellfish poisoning or NSP, and diuretic, and lastly amnestic. It depends on what are the toxins involved. So for example, saxitoxin, brevetoxin, oxidioic, or demoic, in which it is the source is from dinoflagellates as well, in which it's taken up eaten by the fish and accumulated in the flesh. Okay, so it's most it is as it is said as shellfish, so it is from a shellfish such as mussels, oysters, scallop, and clams. And the last one, what I'm going to talk is about scambroid. Scambroid, in which it is involved histamine, in which is a byproduct of bacterial action of histidine in the flesh of fish. So I'll talk about later. So marine poisoning or from biotoxin is a heat and gastric acid stable, in which if we cook it, the poison or the toxin is still there, and it is accumulated in flesh or muscles or skins, viscera or digestive glands or raw, and accumulated through food chain. It do not, if you look at this one, the food chain means the dinoflagellate. Then so dinoflagellate that contains the toxin, and then eaten by a small fish, and then eaten back from the larger fish, and then it accumulated in the flesh. And then when and people and catch the fish, and they take and eat it, and they eat as well as with the toxins. So it is actually for this type of biotoxin poisoning, it does not show any visible sign of contamination on the fish. Unfortunately, we do not have any blood or urine test for that. But if you want to test it, we have to test from the seafood itself, from the food itself. And there's no specific antidote for this. So most of the cases is actually because of the fish or the shellfish use foods or from the alga, and it usually happens when there is algal blooms, and it is the alga is we consider as harmful alga, in which when it blooms out, and then the fish eat the alga, or the shellfish use the alga, and the toxin accumulate in their flesh. So that's include PSP, DSP, ASP, CSV, and Ciguatera, neurotoxin, NSP. So these are the most common, but tetrodotoxin and scambroid is different. So how the alga bloom happens? It's actually at the sea, the alga is there, but when there is something happen that it promotes the alga to bloom out, and then it can the numbers is increased, like solar radiation or disturbance of the sea bed due to dredging, or is it because of the nutrients from the shore that promotes the alga to increase, to duplicate, to increase, and then therefore the numbers is increased, and the fish taken up this alga. And some of the alga that they produce the toxin is actually can go into the surface and cause intoxication. So what is alga bloom? Alga bloom is a spectacular increase in density of a particular microalga species over a short period of time. It's a bloom patch that can contain up to million cells per liter, typically lasts for a few weeks. And then these harmful alga blooms, the species produces toxins harmful to humans and other organisms. So sometimes we say that it's red tide, or alga, when the alga is blooming, is the sea looks different, looks red, but not all red is alga blooms. But in some cases, even though the alga is the density of alga is high, but there's no change in color, it's not necessary the alga blooms manifest with red tide or something else. So this is an example. So sometimes the alga is not taken out from is bring out from other place to other place by the ballast water from ships. So this is one of the studies published from Malaysia, where the the occurrence of harmful alga blooms in from 2000 to 2010. We can see at the even in Kelantan, Selat Tebrau, and from Pulau Pangkor and Penang, and as well as in Kuching and Kota Kinabalu. So it's stated as the organism of the harmful alga like Alexandra minutum and such and others. And then the impact, if you look at the from this from the publication, they involve patients, for example, in Tumpan, and then this one in Kota Kinabalu, and it happens even in Pahang, in 2012. I'll show you later. So we go to the specific poisoning. Number one, I'll talk about ciguatera poisoning. It is due to ciguatoxin, and this ciguatoxin is actually present in dinoflagellate alga that is called Gambia discus toxicus. Okay. When a fish, a small herbivorous fish, eat this alga, and then it there's a biotransformation. This alga, that produce ciguatoxin, and this it accumulate in the small fish, and then it eaten by the larger fish. So lots of toxins is accumulated from this fish and then accumulated in this larger fish, like grouper, amberjack, red snapper. And then when people take this contaminated food with a ciguatoxin, and it manifests, the patient manifests with the symptoms. How ciguatoxin acts, give the what is the how it acts. It's actually the ciguatoxin effects on the sodium channels and increase the permeability, increase the sodium and calcium influx. And some says that some studies shows that there's a blockage of the potassium channel as well. So what are the symptoms and signs? The onset is, it can as soon as 15 minutes after ingestion, and it can within 6 to 12 hours, and if even after 24 hours. It has GI symptoms such as abdominal pain, nausea, vomiting, diarrhea, and painful defecation. And this is the very particular about ciguatoxin, about neurologic. Number one, patient might has lingual and circumoral paresthesia, painful paresthesia of the extremities, and the paradoxical temperature reversal, in which the person feel all objects feel hot and hot objects feel cold. And this is a classical symptoms of ciguatera in poisoning. And some patient may has dental pain, pruritus, arthralgia, myalgia, weakness, ataxia, vertigo, and respiratory paralysis. And in a very small amount, some very small number of patients become comatose. And patient also may has a cardiovascular symptoms such as bradycardia, hypotension, and pulmonary edema, and other general symptoms, sinus symptoms like dysuria, chills, sweating, painful ejaculation, metallic taste, and polymyositis. So how we work up for these patients when we suspect patient has ciguatera toxin? We need to take CK, creatine kinase, because some patient might has a muscle tissue breakdown. And number two, we have to notify to public health and fishery department, because if one person get this poisoning, there's a possibility other person as well. So what they will do is they will check, investigate whether there's a ciguatoxin from the food sample, and even the fishery department can test if the fish is taken up from some places that is known, and then they can test the water whether there's any presence of dinoflagellate. Unfortunately, there's no serum or blood or urine test to work up with. So treatment, more of supportive, airway, breathing, circulation, and decontamination if the patient comes early. And for drugs, number one, activated charcoal if indicated, if patient comes early. Antihistamine, more of symptomatic, if patient had allergic or pruritus. Amitriptyline, mannitol, analgesics, non-steroidal anti-inflammatory drug, and gabapentin. But this one, all the medication given is actually just they don't have a very good evidence base, but some yes, some of the medication given is had reduced the sign and symptoms. So precautions during recovery period, patient should be advised not to have to avoid any fish products, shellfish products, alcoholic beverages, nuts and nuts oil, because it can probably the symptoms can comes again. Okay. Number 2, travelers precaution. We advise try to avoid large fish, for example, more than 2 kilos, especially the predatory reef fish. Eating the do not eat the head, viscera, or raw of any reef fish, and eating fish caught in areas known to be ciguatoxic. Do not do that. Okay, the next one is about toxic shellfish poisoning. There are 4 subgroups. Number 1 is paralytic shellfish poisoning, or PSP. It is involves saxitoxin. Number 2, neurotoxic shellfish poisoning, that involve it is due to brevetoxin. Number 3, diuretic shellfish poisoning, DSP. It is due to okadioic acid. And the last one is amnestic shellfish poisoning. It is due to domoic acid. Okay, this is the global distribution of shellfish poisoning. It's actually it happens all over the world, and then for PSP, quite numbers that is detected, and as well as DSP. So if you look at in Malaysia, there's some of the incidences probably reported for PSP and DSP. So the paralytic shellfish poisoning, PSP, is most commonly happen when patient took contaminated shellfish such as clams, oysters, scallops, or mussels. But some may also got from limpets, chitons, starfish, reef crabs, or marine snails. So it has two significant toxins that causing PSP. Number 1 is saxitoxin. Number 2, goniotoxin. Source is due to dinoflagellates and alga. The shellfish filtered and accumulate the alga, and it is heat stable even you cook well. This is, for example, for our case, the actual case in Kuantan, they cook it well, but then when they took the shellfish, they can get the poisoning. The toxin blocks the sodium voltage gated channel and then cause the symptoms. This is the examples. What are the microalgae involved that contains those saxitoxin or this one goniotoxins, such as pyrodinium. It happens in Sabah specifically, and number 2, Alexandrian Tameya vanichi. So this is also reported in Sabah, Sarawak. And then number 1, Alexandra minutum. This has happened in Tumpat, Kelantan. And Alexandrian onstin, Alexandrium species, Sabah and Sarawak. Most of them are in Sabah and Sarawak. So in PSP, the onset is less than 30 minutes. It can last for about 2 until 5 days. And it neurosymptoms is predominant. Patient might get paresthesia, like lip, mouth, and throat, ataxia, vertigo, weakness, paralysis, cranial neuropathy, respiratory failure, and patient might get GI symptoms or cramps. Hypertension less common. Unfortunately, still the same, no acid available. The estimated lethal dose is 0.3 to 1 milligram. The mortality about 44%. I share I share with you what are incidents, two incidences in our hospitals. It happens in 2012. We have two incidences at the same location, in which it is at the Kuantan port, seaport. The first incident occurs, I think cannot remember, in probably in August. It involves about 4 patients. The more they eat, the more symptoms they get. Okay, so one of the patients eat more than 30 slices of the shellfish, and then they get all of them get GI symptoms, paresthesia, neurotoxic, and 2 of them get respiratory or cardiac arrest. One they got apnea, and then assistole for a while, and then we assist, and actually, fortunately for them, all of them survive after they were discharged after about 7 to 8 days. So the second incident occurs in about 3 or 4 months later at the same place. So it involves 8 patients, and fortunately, only I think none of them got respiratory or cardiac arrest. I think none of them intubated. Okay, so they survive. Within 3 to 5 days, they can be discharged. They are very fortunate that at this time we already know there's a possibility of the PSP. So we anticipate, and they all survive. So after that, we have managed with the authority to close that area, to inform the publics not to take any shellfish from that area. So there's no antidote. It's just management and supportive, ABC, airway, breathing, circulation. Close monitoring, need intubation and ventilator support in respiratory insufficiency, and we have to notify. But sampling, they have to take samples from the fresh samples, and then they send. And unfortunately, the result will come back about 1 or 2 weeks later. So we have to manage the patient according to what are the symptoms and requirement at that time. We cannot wait until the result of the sampling came back. So this is one of the example when they tested for when the fishery department tests for the samples. So they reported as this one. So this is actually the toxin that involves oxytocin and goniotoxin. So STX and GTX, 1 to 3. And then so this is from what are the dinoflagellate that appears, and then this is what they do the studies on multiple places in Malaysia. So the second one on the shellfish poisoning is neurotoxic shellfish poisoning, NSP. It involves brevetoxin from Pithecodiscus dinoflagellate. Still, it acts on the sodium channel, but this one is stimulate the sodium channel and autonomic nervous system. It is a milder form of PSP, usually does not progress to paralysis. Otherwise, same as PSP. The signs and symptoms quite similar to PSP, but the toxin involved is a bit different. It's different. So toxin aerosolized by surf from red tide can cause respiratory symptoms like asthma and rhinorrhea, and abate when leave the beach. So it can surface. So NSP, the onset about 50 minutes, it come up to 18 hours, and duration can up to 2 to 3 days. So neural symptoms predominate, but patient might also has GI symptoms. Patient might have paresthesia, ataxia, bradycardia, bronchospasm. So management is still the same, ABC, supportive, close monitoring. The third one is diuretic shellfish poisoning. So the toxin that involved is ocadoic acid. It comes from dinofish toxins from dinoflagellates, and it is fat soluble, heat stable, still the same. It is rapid onset and lasts about 3 days. It presented with diarrhea, nausea, vomiting, abdominal pain, hypervolemic shock maybe. But fortunately, it is self-limiting, and in some patient who had a severe hypovolemic shock, patient might need fluid resuscitation. But for this one, we might miss this diagnosis because we thought it is just like a normal, the usual food poisoning. Okay. The last one is amnestic shellfish poisoning. So it involves the moic acid. It depolarizes at the spinal ventral root neurons, and the onset is about 5 hours or range from 50 minutes to 36 hours. This also can manifest with GI, neuro, and cardiovascular. So GI, for example, nausea, vomiting, diarrhea, abdominal cramps, neuro, memory loss. So this one very typical in which it has a memory loss. Patient might has confusion, headache, coma, or grimacing, chewing. Ophthalmoplegia, less common. So the patient might also has a cardiovascular symptoms like hypotension and arrhythmia. So management still the same. Airway, breathing, circulation, supportive, and close monitoring. But sometimes probably we have a difficulty because patient cannot remember what they eat. So because of the memory loss. So it is sometimes, most of the time we cannot get the actual history unless patient comes with other friends or relative that also take the same fish or same food. So for shellfish poisoning, I can summarize. If patient come to you after eaten shellfish with symptoms, sign and symptoms, and it is actually a dose dependent. I mean, the more you eat, the more you can get the sign and symptoms, or the more severity. So number one, if patient has neurologic plus, if patient has GI only, GI symptoms, so most likely it is a diuretic shellfish poisoning or DSP. If patient has neurologic plus GI, got three things that we have to search out. Number one, is the neurotoxic predominate with paralysis? If yes, it is PSP, paralytic shellfish poisoning. If the paresthesia and the no paralysis, then there's possibility of PSP. And the last one, if patient has predominant memory loss, then probably it is amnestic shellfish poisoning. So the treatment is actually the same. It's just symptomatic, supportive and manage symptomatic. No antidotes, no immediate diagnostic test. We need to observe the patient and monitor the patient at least for about 24 to 36 hours. And probably we have to keep the patient keep the patient monitor about 3 to 5 days before we can discharge patient. So advanced life support and intensive care in severe cases. This is one of the prevention is quite important as well, because we don't want other person also get poisoned with the marine foods. Primary, avoid eating high risk food, surveillance of algae and toxic marine animal and foods. This one, the surveillance is actually done by fishery department. They do it quite all of they do it in area that is highly suspicious, and they do it quite frequent in a year. Risk communication, and we need to notify if we get the diagnosis. Okay, the second last is about tetrodotoxin. So if you look at this one, we can get tetrodotoxin poisoning after eating like this one. This was the actual case, from Malaysia. The patient take puffer fish. This one is horseshoe crabs and from the blue ring octopus. So how the tetrodotoxin is actually, it has the animal itself can accumulate tetrodotoxin from the environment itself, or it can produce by itself. So it accumulate at the flesh, skins, or even the raw, or even in the glands or the viscera of the animal. How tetrodotoxin effects? Number one, it inhibits the voltage-gated sodium channels. That it prevents cells membranes from depolarizing, and it inhibits axial potential propagation and prevents neurons and myocytes from functioning. So patient will get the neurological symptoms, signs and symptoms. So Fukuda and Tani in 1941 had grade 8, from grade 1, grade 2 until grade 4. So probably this is quite common, or is actually quite common in Japan, probably because they eat the puffer fish, or we call it fugu. So for in grade 1, it only has paresthesia and perioral numbness with or without gastrointestinal symptoms, such as nausea, vomiting, abdominal pain, and diarrhea. So they with or without, it's just paresthesia and perioral numbness in the grade 1. Grade 2, patient has facial numbness, slurring of speech, early motor paralysis and coordination, but with normal reflexes. This is grade 2, normal reflexes. Number 3, when patient already has generalized flaccid paralysis, aphonia, respiratory failure, and fixed dilated pupils in a conscious patient. So patient is still conscious, conscious. And number 4, severe respiratory failure with hypoxia, bradycardia, hypotension, cardiac arrhythmia. The last, in which patient is already unconscious and patient already collapsed. So this is grade 4. So in management, we have to identify it from grade 1 itself. When we already identify grade 1, we have to closely observe the patient. When we patient had grade 3, for even grade 2 or grade 3, probably we have to assist the respiratory. For grade 4, it's already too late. It's too late. So treatment ABCD, decontamination if at early phase, supportive, hemodialysis in some cases, but not enough. But some patient was given neostigmine, but not enough data to support this. So it is more supportive and early, more early detection and supportive. So for our case, luckily patient was intubated, and then patient actually within 2 to 3 days patient wake up and patient survive. So the last one is scambroid. The scambroid, it high histamine levels due to improper processing or storage of the fish. In a flesh of the fish, it has histidine, in which when it is open at the room temperature, the bacteria cause decarboxylation of the histidine, and it convert histidine from histamine. So the histamine, the amount of histamine in the fish flesh is quite high, and when we eat it, patient might has symptoms within 10 to 10 minutes or up to 30 hours. Patient manifests with a allergic reaction, skin flush, rash, urticaria, GI, CVS, respiratory. Treatment ABC supportive, and we can give antihistamine for this patient. So that is a scambroid. So I think that's all. And to summarize from my topic, number 1, we have to suspect a patient has a marine animal or poisoning when they get sick after eating seafood. The management is more of syndromic approach, in which we based on the clinical manifestation, based on signs and symptoms, and management is more of supportive and symptomatic and supportive management, and we don't have antidote for that. To confirm the diagnosis, we have to take from the food samples. But it takes time, about 1 to 2 weeks, then we can get the result. And we don't have any confirmative test from blood or urine or others. And lastly, we have to notify so that no other people can get the same issue. Thank you very much for this morning. I leave it to Nava.
All right, thank you, Dr. Zainal, for helping us become more aware of the problems that occur in marine poisoning. how algae, for instance, are being transmitted to fish and the ways that we can tackle them. Now we move on to our next speaker, Dr. Aida Nur Sharini binti Muhammad Shah, is the head of International Islamic University Malaysia IIUM Poison Unit based in Kuantan, Pahang. She is a consultant for the consultant for Remote Envenomation Consultancy Services REX and the chairman of the Code Blue Committee in IIUM. She has multiple research under her portfolio, one of them as being the principal investigator of eye care, crisis action, research and education. Her motto is do or do not, there is no try. Without further ado, we would like her to present her topic for today, jellyfish stings.
Hi, thank you so much, Nava. Assalamualaikum, everybody, and a very good morning. First and foremost, I would like to thank for inviting me. Number two is that I would like to apologize ahead because I'm actually presenting amidst the FRCAM Malaysian examination. So you might hear a lot of background noises and I'm one of the secretariat, so I may have to run off after this presentation. I apologize that in advance. Anyway, thank you again, Nava, for that introduction. Let me just share my screen. Hang on. I just need to. Okay. Oh, I'm using a new device, so it's asking me to do things. Okay, hopefully I can do this. Can I share? Okay, here we go. Just stop this. All right. Okay, so this is my presentation. So bear with me. I'm also a bit jet lagged. Right. So my topic is about jellyfish stings. So this is the table of contents. Right now, obviously, what we want to learn is how to manage jellyfish sting. So that's the main objective of this talk today. Right now, jellyfish sting is actually very common. I think a lot of you, when you swim in the ocean, you can feel stings and, you know, a burning sensation sometimes, but it is difficult to detect what has bitten you, what has stung you. And it's very common that it is a jellyfish. Right now, usually it's harmless, but there are certain species that can cause a fatality or increase in your morbidity. Right now, in Malaysia itself, there has been a number of cases, and usually it's the same similar spots like in Sabah Sarawak, you know, the west coast of the Borneo Island, and in Semenanjung is mainly also in the west coast area, like our Pulau Pinang, Pulau Pangkor, the Pangkor Islands and the Penang Island, right? And actually recently we had in the news about a French boy who was stung and actually died from all the complications of the jellyfish sting, right? And during, it was in between the peak, during the COVID, where everyone had to be locked in, there was, at one point, there was some prisoner men of war found on the northeast coast of the peninsula of Malaysia as well. Right, and that is another species that is also can cause a lot of harm, right? And of course, this is what we see a lot during our consultation. As Nava has mentioned earlier, the remote environment consultation services, box jellyfish sting injuries. Right now, this is from a study looking at jellyfish death from 2010 to 2000 to 2010. Now, as I mentioned earlier, these are the common locations of jellyfish, reported cases of jellyfish stings in Langkawi, your Penang Island, the Pangkor, the west coast of Peninsular Malaysia, and also the west coast part of Sabah, actually, right, near Labuan and this general area. And these are the common consultations that we get for our REX group. All right. Now, these are the species that I mentioned earlier. These are our box jellyfish. Looks very pretty but deadly, right? The stingers all lie at the tentacles. This is your Physalia physalis, your Portuguese man of war, and this is your Caribdid box jellyfish. Oh, sorry, this is your Kisaroa akinensis. Okay, so some of the examples of the jellyfish that is medically important, clinically important in Malaysia. Right. Most of the time, the patients would not be able to describe. They sometimes say that it's a very cold or very, what do you call it, jelly-like structure that has passed by them, right? And then they felt stinging. Most of the time, they are unable to see what has stung them. Okay, so this is a case in point of a recent consultation in the REX group. This is the REX group, Queen Elizabeth Hospital, and this is a 9-year-old boy who was swimming in the sea and felt burning sensation and pain over his left arm, and that is the common presentation for jellyfish sting. It's usually pain, burning sensation, and where visible, there are some welts, red like welts like this. These are the common presentation of a jellyfish sting. Right now, how does this the jellyfish cause the pain and everything? Now, the jellyfish has this cnidocytes, okay, that contains the nematocysts inside, right? And it's bathed in venom, right? It's bathed in venom, and it has this sharp structure here. It's a cnidocyl, and this cnidocyl acts like a trigger. Now, and it can be triggered by anything. It can be triggered physically, chemically, right? When it's triggered, then it will inject the venom to whatever parts that this tentacle has attached to. All right, so these are all lined at the tentacles of the jellyfish. Right, so that's how it's injected. I will show you a video that is available on YouTube anyway of how this is occur. I think you need to see a video to see how vivid it is that the nematocytes discharge the venom, right? So these are some of the nematocysts that you can look under the microscope. And in our consultation with the REX group, we will ask you to perform some a simple procedure to collect this to identify the nematocysts. Right, so let's just focus on a box jellyfish, the Chironex species. So, like Dr. Zainal mentioned, when they come, you have to look at the symptoms. Right now, most of the time, like I said, the symptom is pain, and then usually it's burning type of pain. It feels like a burning type of pain, and there are welts. Okay, so and the pain can last for a few hours. Now, this is no systemic. This is the no systemic involvement. It's just very localized. Now, if there is a systemic involvement, life-threatening involvement, sometimes it's lethal, about 10%, especially when more than 10% of the total skin area is affected, right? And cardiac arrest may occur as fast as 5 minutes within envenomation. Right, and you might get hypotension, tachyarrhythmias, and respiratory dysfunction as well. Now, the management of these depending on how the patient is presented to the hospital, right? Okay, so the initial treatment. Now, everybody knows this, or if you don't know this, well, this is a might be new to you. But the initial treatment, the phase first aid treatment, is to pour vinegar, acetic acid, over all the sting sites. Right, and what does vinegar do? It actually activates the undischarged nematocytes, right? It activates so that if there are further triggers Okay, remember how this nidacil is triggered, is a trigger and can be triggered by chemical or physical. So the vinegar will stop further discharge of undischarged nematocytes, right? And for at least for about 30 seconds before removing all the tentacles. All right, okay, do not, it's advised against to pour any alcohol, don't rub on it. Okay, some traditional belief put they will rub what do you call it, toothpaste. Okay, so don't do all those. Vinegar is actually have been proven, a lot of studies have been done, and it actually inactivates undischarged nematocytes. Okay, and then you can remove the tentacles. Okay, and you need to immobilize the affected limb, all right, firmly, but not too firmly. The bandage is not too firmly. All right, and then you need to go to the nearest hospital or call for assist to get to the nearest hospital that has a box jellyfish antivenom, right? And in some cases, we will require, when you consult the remote environment consultation services, we will require that you take a sticky tape to take samples. Now, there is a video of all of this as well, and I will share it with you. And of course, you can consult the remote environment consulting services anytime of the day for further consultation. Right? Okay. So in case of cardiac arrest, this is as per protocol. Okay. If the patient comes in cardiac arrest, you follow the cardiac arrest protocol. As soon as the identity or your 5H5P is identified, like you know that this is a envenomation, this usually the protocol is to prolong the CPR. Okay, until you are able to reverse the or you start the antidote. Like for example, if it's a box jellyfish, we have the antivenom, right? Okay, if there is no systemic involvement, of course, there is reassurance, adequate analgesia, and serial observations before discharging the patient home. All right. Okay, so let's just look at some videos. And that trigger can be, and that nidocytes can be triggered chemically or physically, right? So that's why do not use anything else. Do not use alcohol or other formulation. Vinegar is the only one that has been shown to inactivate it, right? Okay. So now some of the immediate and short-term complications include, of course, wound infection. You can get rhabdomyolysis, renal failure, hemolysis, pulmonary edema, respiratory paralysis, and cardiovascular collapse, and of course, death. And there are some long-term sequelae like keloid formulation, granulomas, hyperpigmentation, and contractions. Okay, so again, the treatment depends on the presentation of the patient. Right, now that is all for my jellyfish sting presentation. Hopefully that is adequate. The remote envenomation consultancy services do have courses on marine envenomation that you can join when we have them, especially now that COVID is, well, not over, but we can do face-to-face courses now. So do join us for a more extensive information loading on jellyfish sting after this. Thank you. Back to you, Neva.
All right. Thank you, Dr. Aida, for capturing all our attention so well. She gave us informational updates regarding jellyfish bites throughout Malaysia. So we'll be seeing her back probably later on 11:15 for our forum session. So we'll be having a short break now until 10 a.m. Speaker for today. Our next speaker is Associate Professor Satriya Trakul Srichai. She is the attending staff and consultant of Department of Emergency Medicine and Ramati Bodhi Poison Center, Faculty of Medicine, Ramati Bodhi Hospital, Mahidol University. She is a secretary of the Thai Society of Clinical Toxicology Committee and a working group on venomous marine animals in Thailand. She has received awards such as the Best Original Research Award at the 16th Annual Scientific Congress of Asian Pacific Association of Medical Toxicology at Kandy, Sri Lanka in 2017, the Outstanding and Excellent Researcher Award 2020 by the Thai College of Emergency Physicians, the Outstanding Personal Award 2022 by the Faculty of Medicine, Ramati Bodhi Hospital, Mahidol University. Associate Professor Satria has 36 international publications and has been invited as a speaker in several international events in Singapore, Malaysia, Romania, Japan, Taiwan, and Thailand, with several other virtual conferences in light of the COVID-19 pandemic. Let's welcome Professor Satria with her topic on non-jellyfish marine stings. Floor is yours, Prof.
Okay, can you hear me clearly?
Yes, we can.
Thank you very much for the introductions and good morning, everyone. And first, I would like to thank the Organizing Committee for inviting me to be the speaker in this conference. It's my honor to be here. And today, I will talk about non-jellyfish marine stings. I did not have conflicts of interest, and this lecture is for health educations. The main references of my talk are from the standard textbook of emergency medicines and clinical toxicology. And I am sorry for my hardness of voice because I have a bad cold. So I apologize for that. That I might cough sometimes, and I really apologize. So the outlines of my talk will include mainly for the informations and cover a little bit for traumatic injury from marine stings, including for the spiny fish, Mollusca, and Echinodermata and Nirida porifera as follows. So when I look at the epidemiology of marine animal injuries in our regions, I found one paper from Australia, and the jellyfish is the most prevalent, but they found stingrays and sharks are also contributed for the injuries. And interestingly, that almost 20% of injuries are associated with retained foreign body. When I try to look at the data of the epidemiology of marine stings or injuries in our regions, they are quite limited. And I try to look at our poison center data, and we found that the corn snail, we don't have the cases consulted to us with corn snail, but stingray almost 100 for like more than 20 years. Stonefish and sea star are quite rare and no deaths from these marine stings. So maybe these marine sting cause only like my symptoms and my effects. No deaths occur from this marine animal based on our poison center. And for marine venoms, typically high molecular weight and heat rate by protein. So that's why some experts use hot water immersions to the nature of these venoms. I will begin with the spiny fish or venomous fish sting that they contain, they have the sting that can injure our patients or humans. For spiny fish, some belongs to Scorpionidae family, like lionfish, stonefish, or scorpion fish, and stingrays belongs to the phylum Chordata, but it commonly reported to injure for human injury, and catfish also envenomate humans and injure humans. I will begin with the spiny fish, the stingray. There are the reports of about 2,000 stingray injury in USA, and most from the stepping on this animal, and that there are also the fatality reported from these spiny fish, like from the wound, hemorrhage, or tetanus, or the trauma. And for the stingrays, you might hear about like the famous animal activist Steve Irwin. He died from the stingray injury. And so the stingray or the tails contain or have the venomous spines and inflicts the lacerations. So most patients were injured by stepping on the body of the stingray, and it's caused a reflexive whip of the tail and inject the venom to the human. And the venom contain many substances, and in animals it can cause several systemic effects like arrhythmia or seizure, and also can cause death in animal models. And for the clinical manifestations of stingrays envenomations, besides only it can injure by cause the traumatic injury, it can cause immediate local pain that is out of proportions, may radiate and last for many hours, can cause bleeding, depend on the site of the injury, and can cause a local effect like edema, erythema, and petechiae, ulcerations, or necrosis in severe cases. The main concern is the stingers that is retained in the wound, or the wound infections, or the injury to the vascular or the tendon to our patients. It can cause systemic effects, but it's not, the systemic effects are not common, right, in nausea, vomiting, like GI symptoms, seizure, fasciculations for neurological symptoms, and hypotension and arrhythmia for cardiovascular symptoms. It can cause injury, the wound, and tetanus also. For the diagnosis, most we diagnose the patients from the history that they step on the stingray. So the most commonly affected area is the lower extremity, and sometimes we have to perform the imaging of the affected body part to find the retained foreign body, especially when we suspected that the patient has retained foreign body, because the spine is denser than human tissue, so it's easily identified on the X-ray. But for negative study, you might perform ultrasound to find the retained foreign body. For other venomous fish sting besides the stingray, stonefish, weaver fish, scorpion, and lionfish, the clinical effects range from like very severe from stonefish to the minimal like the catfish or other fish with non-venomous spine, and apparatus vary among species. For the stonefish, scorpionid, the spine cover with the sheath, and the amount of the venom released is proportions to the pressure applied to the spine. Stonefish contain 3 main toxins, and in animal model it can cause systemic effects like vasodilatations and hypotension. And for stonefish, the main clinical effects are the severe and increasing local pain and local effects. The pain typically peak about 1 hour and persists for 4 to 6 hours, but may persist for days. And the wound site might have the edema and erythema. The stings sometimes are associated with the compartment syndrome, and wound healing is quite long, as months. And this is the picture of the stonefish. The stonefish can cause systemic effects, but it's not common, like GI symptoms, seizure, paralysis for neurological symptoms, and again that for cardiovascular like arrhythmia and hypotension, congestive heart failure. But it is not commonly reported. Like when I look at the data from Hong Kong retrospective review of stonefish, the main clinical symptoms are like local effects like pain, swelling, and erythema, and relief by hot water in immersions and analgesics noted in that study. And for the lionfish, sometimes in the aquariums, the patients injured from the aquariums like in the house. The effects include like the pain, GI symptoms like nausea, vomiting, numbness, joint pain, dizziness, and some develop like cellulitis. And from retrospective study, mainly the clinical effects are like the pain and the local effects. Some develop like numbness and dizziness, but no serious systemic effects occur from this study. For other venomous sting like beaver fish, the pain severity is similar to like stonefish, and the wound can be necrosed and sting. Envenomations is similar to scorpididae envenomations, but rarely cause systemic effects and death. So it like other venomous fish sting, especially for the local effects. And the catfish, the injury of from these fish are comparable to other stinking fish. So for the venomous fish sting, the management for or venomous fish sting, we will pay attention on the wound care, like clean, irrigate wound, and examine for the retained foreign material. We buy for necrotic tissue, and we have to consider about imaging to visualize retained foreign material. And hot water immersions in about like 45 degrees Celsius can denature proteins, venom, and help relieve the pain. So hot water immersions is recommended commonly for these venomous fish sting, and other analgesics like lidocaine and other oral analgesics also. And we have to give tetanus shot to the patients and prophylactic antibiotic, especially in some immunocompromised horse. And stingray wounds is the greater potential to cause necrotic and infection. So we have to pay attention more for stingray wounds, especially for the stingray wound. And for the stonefish envenomations, indeed, there is the anti-venom, but we don't have in Thailand, but I'm not sure in other country. It's used for severe systemic reactions, but we don't have. So mainly that you see from our data, we have no any severe cases, so we have no this antivenom in our country. So from like recommendations from textbook of emergency medicine for spiny fish, they will recommend hot water immersions and lidocaine for detoxify and wound care. And so for antivenom for severe systemic reaction. And I will go back a little bit. For stingray, you have to concern about like deep penetrations from the spine injury of the stingray. And for the conclusion of fish sting from venomous fish sting, local effects are the main effects of these fish sting, and severe effects can occur, but it's not common, and death is very rare. Systemic effects include like GI, neuro, and cardiovascular effects, and wound care is the main treatment for these patients. Hot water immersions for pain relief, tetanus, analgesia, and consider for prophylaxis, antibiotic, and imaging for retain foreign body or spine in the wound. The next one is Mollusca. Mollusca, the final Mollusca, the class Cephalopoda include octopus, squid, and the main one that you might hear about like is ruling octopus, and the gastropoda is corn snail. I will start with the ruling octopus. Ruling octopus inhabit in our region, I think. In Thailand we have, and it's quite small. It's yellow, brown color, but it can flash the rulings when they are frightened or they are threatened, and it's not aggressive. Bites humans commonly when the human handle it, and there are some reports of death from these octopus. This is from the news in Thailand, and you can see that ruling octopus was sold in the market for eating, and it's quite a little bit dangerous. It's quite interesting that it's dangerous, and you can see that it is in the market of the seafood market. And bullying octopus, the posterior salivary gland of it its salivary gland can produce tetrodotoxins, and so its saliva contains tetrodotoxins and introduced by a bite. Tetrodotoxins block sodium conductance in the neuron. It can cause paralysis, respiratory arrest, and hypoxic cardiac arrest. Venom contain other substances, and hypotension can caused by reductions of vascular smooth muscle tone. So poisoning from bullying octopus is similar to tetrodotoxin, and one might concern that consuming or eating bullying octopus can cause poisoning. By personal communications with experienced fishery scientists, they say that maybe more than 6 or 10 octopus can cause poisoning because it contains tetrodotoxins inside the body of octopus. So tetrodotoxins produced by bacteria and is accumulated in the marine animal as like bullying octopus, and it is stable. So this is the paper that from Japan that tetrodotoxins is in salivary gland, gonad, and hepatopancreas and other. So when the patients might eat a lot of bullying octopus, it might cause poisoning. But there is, I think that I try to find, but I don't see any report from consuming bullying octopus or from the bite of bullying octopus. So for the clinical effects, most commonly they bite on the upper extremity, especially when they were picked up. The bite was small and painless, and many were unnoticed. And then the bite can develop like a veal, erythema, tender, and pruritus. The poisoning is identical to tetrodotoxin, so it causes paralysis. And besides only paralysis, tetrodotoxin from bullying octopus can cause peripheral vasodilatations with profound hypotension, and the onset is very rapid, right, in minutes. So most cases, they have no any symptom or only mild symptom, numbness or paresthesia, but severe can occur. The patients can have progressive fascist paralysis with respiratory failure without depressing of mental status, perioral numbness, lipopia, and fascist paralysis, and can cause death. It can take about 24 or to 48 hours by near complete recovery. For some severe cases, they can develop only like severe sign. And this is the grading for tetrodotoxin. And you can see that the grade 4, the patients can have like severe respiratory failure, bradycardia, and arrhythmia. And for the diagnosis, main from the history, and tetrodotoxins can be detected in the urine and serum, and by the spatial labs. The differential diets include like botulism, Guillain-Barré, or foodborne neurologic toxicity, but botulism did not, it has no any like sensory symptoms. Guillain-Barré has the hyporeflexia, and foodborne neurologic symptom toxicity like from Ciguatera, they might have other symptoms. So these are the differential diagnosis of this bullying octopus, and this is the acute lesions, and this is the chronic lesions that non-healing ulcer remain. For the management, ABC and ventilator support, especially with the patients who has respiratory compromise, about 1 to 2 days. Hypotension, you can give phenylephrine or norepinephrine. From the study, epinephrine and dopamine lack efficacy for these symptoms. And local wound care, tetanus, and some might recommend pressure immobilization for the first aid treatment, and most recovery like in 1 to 5 days, and we have no antivenom. And this is the pressure immobilized, the same as in the snake bite. And other study treatment for tetrodotoxin include like neostigmine or vaccines or hemodialysis in uremic patient, but there are no any enough evidence to support the routine treatment for tetrodotoxin. The corn snail is nocturnal feeders, and it can cause death in worldwide. And the corn snail inject the neurotoxins by use the proboscis. This is the proboscis, and chronotoxins in venoms contain many substances. And the chronotoxins or the corn snail contains 3 superfamily of the toxins, and it affects like nicotinic receptor and voltage gauge ion channel like potassium, sodium, and calcium. And these all resolve weakness and paralysis by the voltage gauge channel of the calcium, sodium, and potassium, and nicotinic acetylcholine. And for clinical manifestations, things are very rare, but it can cause local symptoms ranging from like only slight thing to the severe pain, ischemia of the tissue, cyanosis, and numbness. And it can cause systemic effects. Like you can see like weakness, diplopia, paralysis, and dysphagia, mainly for neurological effects, and paralysis can develop very quickly. The diagnosis mainly from the history, that the point of entry, they pick up the snail or the lab is not routinely available. For the management, ABC, resuscitations, wound care, tetanus, and some recommend hot water immersion for pain relief, but no data that it enhances systemic distributions of chronotoxins or not. Pressure immobilized that is recommended by some experts. And paralysis need mechanical ventilations, commonly resolved within 1 day. Arrhythmia, because it affects voltage gauge channel, like sodium channel. So EKG and monitoring telemetry are needed. And when the patients develop arrhythmia, the treatment is electrical cardioversions, the anti-arrhythmic, especially for sodium channel blocking, might not be effective. And for hypotension, IV fluid and norepinephrine. And you can see this, the corn snail is recommended for hot water immersion for detoxify, and pressure immobilizations that from textbook from emergency medicine. And for broiling octopus and corn snail, in summary, like broiling octopus, they bite, and the poisoning is the same as tetrodotoxin poisoning, paralysis. But another one that is the main concern from broiling octopus is hypotension, and the main treatment is supportive care, especially respiratory care. And corn snail local effects are the main symptoms in most patients. Systemic symptoms can occur like neurologic effects, death, and cardiovascular. So EKG you might monitor, especially for the severe patients, and supportive care is the main treatment for these snails. The last one is Echinodermata, Annelida, and Porifera. Echinodermata includes sea star, bitter star, sea urchins, and Porifera includes sponge, and Annelida is a segmented worm. Most things are mild. No systemic effects are commonly reported, and you can see that Porifera and Annelida and Echinoderma from animal phylum, and Echinoderma urchins and sea star. Annelida is earthworms and leech. And for sea urchins are covered by the spine and pedicellariae. This pedicellariae is generally contain more venom than spine and more difficult to remove from the wounds. It's the pincer-like appendages used for feeding and cleansing and defense. And other substances are in the venom also. And this is the sea urchins, the regions of sea urchins, and this is the petty, which is petty cerariae that you can see that is contain venom also. And so for clinical manifestations, the burning sensations, local tissue reactions, edema and erythema, and some contain neurotoxins. And retention of the spine and fragments cause painful granulomata, and spine penetrations to a joint cause synovitis. Acute pain usually subsides over hours, but if the patients develop delay effects, you have to concern about secondary infections, granulomata formations from remaining spine fragments, and systemic fissures can occur but rarely reported, numbness, bronchospasm, and hypotension. And for C-star, it's less noxious because it has short branch spiny projections, but the crown of thorns, it has longer sharp spike, contain the toxin saponin, and cause systemic effects. So for clinical manifestations, C-star and crown of thorn, the main clinical effects are the local effects, but it can cause like contact dermatitis. But the crown of thorn can cause other like nausea, vomiting, neurological symptoms like paralysis, hepatic necrosis is reported. And in severe cases, the wound can be discolored. So systemic effect commonly from multiple puncture like CNS effect, GI effects, paralysis, numbness in some severe cases not commonly occur. And hypotension is also reported. For management, wound care, analgesics, and hot water immersions is recommended for pain relief, and you have to give oral analgesics to the severe pain patients, and lidocaine, and the spine that sometimes is frequently covered with attended extractions. It might need surgical exploration, or interarticular spine, it needs surgical removal with orthopedic consultations. And soft tissue radiograph like ultrasound MRI may be helpful for retained spine explorations. Antibiotic prophylaxis is recommended for patients with immunosuppressive risk factor and more infections like from skin flora and marine flora. And so for cucumber and bitter worms, envenomations cause mainly local effects like inflammations, rash, typically mild and resolve hours to day. The blister can be removed by the faucet or have adhesive tape. Some recommend to pour with vinegar and steroid, but it's not routinely recommended. And for the sponge, it can cause erythema, papule, vesicle. It can cause mainly, again, that local effects. Some develop systemic. And when the patients contact with sponge that colonize with the nidaria, it refers to the spondylar diseases can cause dermatitis with necrosis or stinking sponge dermatitis. How to remove the spicule? Some recommend using adhesive tape or the edge of credit card. And for hydroid and file coral, hydroid is tiny jelly and file coral look like coral, mistaken as the seaweed. The contact with these hydroid and file coral cause the pain, the wheals, and urticaria. And most extensive exposure can cause like blister, hemorrhagics, and recent crust over a few days. Management like vinegar, analgesic, and wound care and supportive care are recommended now, right? You can see, right? But in the table, they recommend irrigate with the seawater and saline, but from some might recommend vinegar. And so for in summary of these marine animal, sea urchins, you have to concern about retention of spine, the local effects, and the joint for synovitis. Local are the main one. Systemic fissure is rare. especially supportive care and wound care are the main treatment, analgesia and hot water immersion, and other marine animal like sea cucumber. The local effects are the main one, with the supportive care, wound care, analgesia are the main treatment. And another thing that you have to concern is the infections, because besides only human flora, but marine flora, especially for the patients with underlying conditions like liver disease, they are more susceptible to Vibrio infections. So you have to concern about prophylactic outpatients antibiotic or admissions with IV antibiotic in some immunocompromised patients or some severe patients. And the antibiotic are recommended for like quinolone and third generation cephalosporin. And in Thailand, we have the knowledge management from Department of Marine Coastal Resources that contain about the clinical symptoms and the treatment, bedside treatment, first aid treatment in the website that I use some pictures from this website. So in conclusions, most marine sting besides jellyfish can cause only like mild and local effect, systemic effect are there. Including like GI, neuro, and cardiovascular. These are very rare and significant morbidity result from bite and sting. That the pain, retained foreign body, infections, and respiratory compromise, hemodynamic instability, and in-organ toxicity are the main one of to cause significant morbidity. Supportive care, wound care, analgesics, and hot water immersion in some animals are the main treatment in these marine stings. And thank you very much for your attention. สวัสดีค่ะ
Thank you, Professor. He is currently at the Department of Biology, De La Salle University, Manila, and is a project leader for several projects, capacity building on reef assessment and coral taxonomy phase 2, CBRAT 2, examination of the impacts of possible eutrophication in the reefs of Tubata expert, jellyfish ecology and envenomation project, JEEP, refugee, reef functional and genetic diversity, collaboration on resource management among academy and local communities, coral, and several other projects under his portfolio. He has received several honors and awards with 21 publications and 4 books, with one of them titled Matyang, State of Coastal Habitats in the 6 Philippine Marine Biogeographic Regions, winning the National Academy of Science and Technology 2021 Outstanding Book Award. We welcome Professor Wilfredo to present on box jellyfish envenomation along shallow Philippines shorelines are preventable. Professor Wilfredo.
Hey, good morning, everyone. Thank you for the opportunity to talk to you about box jellyfishes. As I was introduced, note that I am not a medical professional, but I believe marine biologists have something to share in a forum such as this. So I'll talk about our work in a project entitled JEEP. And so box jellyfishes are known as the most venomous marine animal known. And for this, they're usually referring to the Australian species. The effects could be varied, but usually, especially if you're stung in the face or in the chest, you could be dead in minutes. So the mechanism was described earlier in Dr. Aida's presentation. The tentacles of these animals could be up to 3 meters long. They're mostly invisible, and they bear these stinging cells, and if enough venom is injected, like was stated earlier, the sting can be lethal. In the Philippines, there's a good number of sensationalized cases, including celebrities, but there an estimated 20 to 40 people are killed in the Philippines every year. And most of these cases are unreported. That's why the number is an estimate, but I have experience being stung myself, and I believe those estimates. This is the Australian species, also known as the sea wasp, described as the most venomous marine animal known. It preys on shrimp, prawns, and small fish. And they are known to breed in brackish water in estuaries. The species in the Philippines and Japan is known as Chironex yamaguchi. It's a smaller animal, but it appears it is a more deadly animal because Chironex fleckeri kills about 1 person per year in Australia. But as I pointed out, the estimates in the Philippines is much higher. In fact, the first deaths due to jellyfish stings in the medical literature, in the scientific literature, is a 1908 paper in the Philippine Journal of Science describing the death of a 12-year-old boy in Manila Bay. This is a video of what we believe to be Yamaguchi. Okay, we are still waiting for the results of the DNA barcode analysis of our samples. And so we're not certain of the name yet, but we believe this is Yamaguchi. Notice the size, notice the largely transparent tentacles. And actually, if you look closely, you will see a small fish inside the bell. They can swim very rapidly, and they have well-developed eyes. They are known to respond to shadows, and related species can even swim and avoid mangrove roots. Okay, so unlike most jellyfish, they can swim actively rather than drift along with the currents. There's a newly described Chironex from Thailand, Indrasakchie. Sorry if I mispronounced that. But please note that there are other species that appear to be undescribed. And it's important that we learn to recognize the species because the action, perhaps even the antivenom, perhaps even the first aid may or may not vary with the species. One of the things that need to be examined, should a sample be available, is where the tentacles connect to the square-shaped bell. Okay, it's square-shaped, hence the common name box jellyfish. And if you look closely at the base of those tentacles, called the pedalium, there's a pedalial canal, and its shape can help you distinguish the 3 species and perhaps the newer species that have yet to be described. Okay. It's very important that the species that stung a person must be identified. So They are widespread in this part of the world. The red map shows where the Australian species occurs. So it extends to parts of Indonesia, to New Guinea. The species in the Philippines extends all the way to Japan, but that's easy to understand because the currents are heading from the Philippines to Japan. But notice, even in Australia, there's an undescribed species. I mentioned there's a newly described species from Thailand, but there's also others that have yet to be described. So there's a chance that the species in Malaysia and Indonesia may not be the same, or there's more than one. Okay, so please note that fact. There might be more than one species in your countries. And of course, as shown in the earlier presentation, there are other jellyfish and other marine organisms, and they might be responsible for specific envenomation, especially if the organism that did the stinging was not observed or was not collected. Okay. This is an example of images, examples of images of these stings. The tentacles leave what has been described as ladder-like marks on the skin. Most victims are children. Most fatalities are children or women. And I'll explain that later, but it has to do with the body mass, but it has also to do with body hairs. The marks can remain for months, and I have personally observed sting on marks on a 60-year-old man, and he was stung as a young boy. So the point there is there are other jellyfish species out there, and we hardly know anything about these species. So let me describe our work on trying to understand the ecology of this species. We study the ecology because we believe that we can avoid getting stung by these organisms. And for many remote areas, especially in our country, that's the best thing you can do, is avoid getting stung to begin with. So the monitoring we do for these animals is fairly simple. We pull a simple net along, held together and kept rigid by PVC pipes. We have trained community volunteers, citizen scientists, to do this monitoring. And we argue that this should be done in more areas so that we can have a better understanding of the ecology of these animals. We also monitor environmental parameters, and we find, for example, that wind direction and wind strength is important to measure in coastal areas because they relate to whether the animals are going to be found closer to the shore, especially in areas where there is a lot of coastal tourism. So these are just satellite maps of some of the places we monitored in both Western and Eastern Philippines. If you want to do similar monitoring, I suggest you go to stretches of beaches like this, where there are no obstructions from the reef. Okay, so you can see a small reef in this image here, and the monitoring is best done where there are no corals between the beach and the open sea, which is not the case in this part, but this is a suitable area for monitoring if the beach extends to about waist deep. Okay. Most of our data comes from Eastern Philippines, popular tourist destination known as Caramoan. That's the name of the town. And let me show you some of our initial results. Like I said, we're still waiting for the DNA barcode results to confirm the identity of the species. And we are winding down the monitoring this year. We have over a year's worth of data, but the patterns are still consistent with what I'm going to show you and in what we have published so far. So this is a photograph of what we find in these nets after around the peak period. Notice that several individuals could be found. You have the fist of a person for scale here and here. So they're about fist size, but I can tell you the sting of even the smallest animal is extremely painful. One of the things that we learned from this monitoring is that their abundances peak about the time of the highest high tide. And note that the highest high tide usually is around the peak of the full moon or the new moon. Okay. These are referred to as spring tides. This is when the tidal range is highest. And about the time of the highest tide is where we find the most animals in waist deep water along the monitoring beach areas. Here's a graph of that pattern shown as numbers in the previous slide. The data was standardized and normalized. The blue lines represent the jellyfish counts. The orange lines represent the tide. And so the typical pattern is the tide will peak, and then the number of jellyfish encountered spikes or increases. And that is consistent, except for this one situation, but this is actually just based on one individual. By the way, the publications emanating from our project so far are in open access journals that you can download freely. This finding is consistent with a model presented for the Australian species. So if you have winds blowing towards the shore, that will help the animal approach the coastal areas. If the wind is not strong enough to create big waves, then the animals are even more likely to approach shallow areas. The reason for that last statement is because waves make the animal swim towards the deeper waters where they will be less affected by the waves. But if they are blown towards the shore and that same wind does not create big waves, then the animals will be found in shallow water. Okay. So the same conditions that most beach goers look for, calm waters, shallow waters, and put in a wind blowing towards shore. And that combination spells trouble for box jellyfishes. This finding is consistent also with what we learn from looking at social media reports of deaths around the Philippines. There's one example. The death was recorded in this town, Lagonoy. It happened in summer of last year. The victim was stung at around 9 a.m. and the highest tide was recorded at 8 a.m. And the northeast monsoon was blowing at this time, which meant the winds were blowing towards the shore. And that led to the death of a 5-year-old. I mentioned earlier, most victims are children or women. Okay. And this is the plot of the tide in that area. Here's another one, same province, but the opposite side of the island of Luzon. The town is Del Gallego. The victim was stung at around 1 p.m. Highest tide was around 4 p.m. The sting occurred in June 6. The new moon peaked at June 10. By that month, the wind that was stronger was the southwest monsoon, which again meant that the winds were blowing towards the shore. It led to the death of a little girl. Okay. Stung at around 1 p.m. Highest tide was around 2 p.m. There are many records in social media, but likely that is an underestimate. Okay. Last year, about there were around six fatalities last year, including 2 in Manila Bay. So this is likely an unreported or poorly reported occurrence. Hence that estimate I showed earlier, 20 to 40 people per year in the Philippines are killed by jellyfish stings. But we don't know if it's the same species or even if it's actually a jellyfish sting. Because the problem is if these deaths are even recorded, the only cause of death listed is drowning. So the jellyfish envenomation problem is in what's referred to as a measurement trap. Okay, because there's very little data about it, the problem gets ignored. And because it gets ignored, resources are not devoted to actually measuring how big the problem is. So what does this mean? It's best to assume the animals are always around. The Australian species is known to breed in rivers up to a kilometer from the sea. And so the cases of fatalities we are recording, they all happen within 5 kilometers of rivers, potentially where the animal is also breeding. They move towards shallow waters when there's very little wave action, but they are blown towards shore by the winds, and their numbers peak at the flood tide when the tidal range is highest, which means the incoming tide will be stronger. This has been presented earlier in Dr. Ida's earlier presentation. Please note that the vinegar is meant to neutralize the stinging cells that are found on the victim's skin. Because the tentacles break off, the stinging cells can actually be released and float around in the water. And so even if the animal is no longer around, the stinging cells might still be there. And the weak acid, which is what vinegar is, neutralizes those cells. It does not do anything about the toxin already injected to the victim. But the first aid measures are meant to try and reduce the number of stinging cells adding to the toxin load already in the victim. Okay. Please note as well that the skin at the palms of people are thicker than elsewhere in the body, except maybe for the soles of the feet. Okay, and so these stinging cells may not penetrate the skin on the front of your hands, but they can definitely sting you elsewhere in the body, including the back of the hands. And so if you touch the surface with these stinging cells, some of these cells might stick to your hand and you will not feel them. But when you touch other parts of the body with those same hands, then those stingers, if not neutralized, will still fire. Okay. You definitely have to get the victim out of the water, and you definitely have to seek medical help because for other species, the effects may not manifest while the victim is still in the water or in the beach area. Finally, I want to talk briefly about protection. These stinging cells, the active part of the stinging cells are actually not very long, okay? Which means most clothing material are thick enough to protect you from getting stung or those tentacles, those stingers penetrating your skin. Okay. However, if the weave of the fabric is rather porous and you press on that fabric, the tentacles may be crushed through the fabric. Okay. And the other way that the stingers can get to you is if you have, even if you're completely covered, where the pieces of clothing meet, small gaps, the stingers can get in there. Remember, the tentacles and the stingers can detach from the jellyfish itself. And so you may want to put a thick layer of petroleum jelly there. And because of the stingers that are not neutralized, be careful when removing and handling those contaminated clothing. Okay. So again, this is another diagram of those stingers. What I was saying is this thread tube is not very long, and the stingers have been studied, various materials have been studied. Lycra suits are best. Wetsuits are very thick, but they're also very warm, and people are not likely to keep them on because of overheating. So they will not be used, and they will not be used if then they won't protect you. Notice that even pantyhose is thick enough to provide some level of protection. So the material need not be thick as long as you don't crush the tentacles through them. And as mentioned earlier, most important is you protect the kids, because most fatalities are children and women, and it has to do with body size and body hairs. So thank you for listening. Thank you for the opportunity to share with what I understand is an audience that's mostly made up of medical professionals. Good morning.
Thank you for sharing your expertise, Prof. Wilfredo. You made a difference to all of us today. All right, we will be having a short break for 15 minutes and we'll continue at 11:15 a.m. with our forum session. Please post your questions in the Q&A sections. Questions will be answered in the forum session. Please stay till the end as the QR code for CPD points will be available then. Feedback and certificate form will be also shown at the end. Thank you.
Jellyfish can be found across the tropical world. This jelly-like creature appears to be harmless, but this creature can cause danger to swimmers due to the toxic once in contact with them. In Malaysia, jellyfish are found during certain times of the year, especially in July and September at the beaches. In 2016, the emergency department at Langkawi Hospital conducted a study. They claim that the published data on jellyfish stings in Malaysia are limited, despite the fact that we live in a tropical climate and are surrounded by water. A journal paper published in 2011 recorded that 3 fatalities caused by jellyfish stings on Langkawi Island, Kota Kinabalu, and Pampur Island. 5 incidences of near-fatal envenomation in Langkawi were also described in this publication.
From January 2012 to December 2014, 759 individuals with jellyfish stings were studied, with the highest number of visits in July, October, November, and December. According to statistics, the average age of the patient was 26.7 years. 59.4% of them are men, 68.1% are foreigners, and 40% were stung between 12 p.m. and 7 p.m. At least 90 patients had Irukandji or Irukandji-like symptoms. Chenang Beach had the most recorded incidents with 590 cases recorded, followed by Tengah Beach and Kok Beach. During the research period, the patients were managed symptomatically and there were no fatalities. Based on the guideline for the treatment of jellyfish envenomation in Malaysia, the presentation of box jellyfish, which is chironex species, are divided into 2. The first one is systemic involvement that can be life-threatening, and the second one is local involvement. Here is the presentation of box jellyfish that can be life-threatening to the victims. For systemic involvement, potentially lethal when more than 10% of total skin area.
All right, welcome back to our 4th Emergency Medical Seminar Series forum session. We will now begin our forum session by answering the questions. I would like to ask all speakers to turn on the video. All right, so we will address the first question. First question was by Ashley. Can fresh urine be used for jellyfish stings in place of vinegar? If vinegar is not available, what other options are? I'm combining that question with Norlina. Can we use beer instead, as beer contains acetic acid? Is there any difference between beer or any other alcohol? Any takers?
Again, with the caveat that I'm not a medical professional, alcohol makes the stingers discharge. It does not neutralize them. A weak acid does. So I don't think beer is a good idea in the absence of vinegar, I suggest carbonated drinks because they're also weakly acidic. So that's what I know from the reviews that I have read that 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 are closer to marine biology than I don't read medical journals regularly.
Thank you, Prof. Wilfredo. Dr. Zainal, any opinion that you want to put in it?
Thank you. I'm not keen to be pissed on my arms when I've been sting. So I don't think urine is a good choice. So I don't believe on that. So I keep with the vinegar. Probably other options. I'm not sure on that. Probably Prof. Khaldun has a better idea. Thank you.
Okay, thanks. Yeah, I mean, those are the common so-called intervention by the public, especially. All kinds of material has been used, including sand, has been scrubbed over the area to remove the tentacles. And those are actually, as Prof. Lee Kuan An mentioned, it will trigger the undischarged nematocysts because of the contact that they have to the undischarged tentacles. So if we have vinegar, yes, use vinegar to basically stop from the other nematocysts from discharging. But if we don't have, then if you want to use just the seawater, and just to wash it off, to rinse it off, okay? But the best thing is just to basically get to the emergency department as soon as possible. But along the way, there are other methods that has come to light recently. Now, vinegar has so-called caused a bit of a controversy with the recent in vitro study, not clinical study, but in vitro study that showed the nematocysts which has already discharged to be further triggered by the presence of vinegar for another about 30% of the leftover venom that is still not discharging. So it has discharged, okay, but when you apply vinegar, it causes the discharged nematocysts to further release the venom. But for the ones that are already not discharged, then they will be deactivated, okay? So that is not a controversy issue. The issue now is the area that is in contact with the tentacles and the nematocysts that left behind, will it add on to more envenomation after the first incident of triggering the nematocysts. So that was what is found in the lab, but how it applies in clinical setting, in situation where there are actually higher risk of getting other people injured and perhaps other injury, then that 30% may not become substantial in a sense because you have already being there and so on. So the immediate issue that you may think of, the pain has already triggered. It doesn't really cause more pain when more things comes in. The pain is already severe, right? But the thing that is actually injury that can cause more harm after that is perhaps go into systemic envenoming and cause cardiorespiratory arrest. So if you are already attending to the patient, then we assume the most important component of that incident is the response to the incident is doing CPR, right? So you're able to provide basic life support to the patient en route or while waiting for the emergency services to arrive at the scene. So that's one more thing that we believe our public, especially, to understand is that yes, the vinegar is important, but if let's say patient collapse, then the next step is not pour more vinegar or ask the patient to drink vinegar, but it's actually to provide CPR to the patient. That's why we have to, when we do this campaign for public, we have to really look at simplicity of the interventions that we want them to apply, and also provide the safety culture of actually having some knowledge of how to do basic life support for the public. So that will come in very handy, especially in areas of, the crowds and the beach and so on, where there is no provision for first aiders or what we call as lifeguards at the beach. Many of our, I'm not sure about Philippines, Thailand is a bit more advanced, but in Malaysia, some of our beaches are not adequately provisioned with lifeguards. Maybe in Langkawi, some of the what we call touristy areas, or even private beaches of the resorts and so on, maybe they have employed lifeguards during certain time of the year where they have more people at the beach. But most of the time, we find the cases that occurred, there are no immediate lifesavers available on the beach. Okay, so that's the issue. And as you know, we only have very small amount of time, little time, less than 4 minutes or 4 minutes max, for us to actually maintain circulation to supply oxygen to the brain. So if you have cardiorespiratory arrest and no CPR was done after 4 minutes, then you could actually looking at irreversible damage to the brain, and therefore maybe quality of life as well in the end. So again, the emphasis here is they provide an intervention that may be minimizing or reducing more harm to the patient. And on top of that, you need to maybe support if the life, if patient collapse before arriving to hospital. Okay, so vinegar is the way to go. The other substances so far, yes, as the Prof. Wilfredo said, some of the other chemicals or drinks, for example, Coke and so on, maybe there's no further discharge. But that is a bit more expensive than vinegar, Prof. Wilfredo. So this is more provision is more easier with maybe easily more available on the beach as well with vinegar. Okay, so in Malaysia we run a campaign that if you want to go to the beach, bring vinegar along. Whereas, for example, in Australia, vinegar, or even Thailand, they provide vinegar for the public at the beach. If you do that in Malaysia, maybe people will take the vinegar and use it to top up on their fried noodles and so on. Yeah, so not for a jellyfish sting. Okay, anyway, jokes aside, but I think that's the simple kind of message that we want to send to the public is just pour vinegar and get to the hospital as soon as possible. Yeah.
Thank you, Prof. Khaldun. Prof. Satria, how's the situation like in Thailand? Is vinegar readily available in all beaches? How's the situation like in Thailand?
I think now in Thailand we have the vinegar poles. I think in every beach, maybe because it's from our Thai authority, they support the use of vinegar for jellyfish in Thailand. So vinegar pole is located in every beach, I think. However, even we have the pole and vinegar, but sometimes when they would like to use the patients who suffer from jellyfish envenomations would like to use the vinegar, but there is no any vinegar in the pole. That's the problem. Sometimes one told me that the monkey took it. And maybe if someone use it, and how about the replacement of the vinegar? And but Thai authority concerned about the vinegar to use for jellyfish. So I think they try to do their best to keep the vinegar in every beach and available all the time.
That's great, Prof. Satria.
Thank
All
you.
right, so we will get to the next question. it was addressed to Dr. Aida, but Dr. Aida is not with us here. I would like to clarify if the Scotch tape technique was the same technique used to get the nematocytes that would be observed under the microscope. Yeah, so about sampling techniques for the nematocytes, if there is no cellophane tape, can we use Scotch tape instead? I think
that question is very much self-explanatory, because the reason why we use a cellophane tape, because it's transparent, right? So when you collect the nematocysts on the tape, if it's stuck, then you put under the slide, then it has to be able to penetrate light for us to see what's on the slide. So if you use a clear, maybe a clear type of adhesive, then yeah, that is possible. But if that adhesive is, you know, is not clear and prevent lights, you cannot see anything under the microscope. So that defies the purpose of nematocyst sampling. So the other method that you can do if you don't have a cellophane tape is actually to do scrapings. So wound scraping. So the disadvantage is you create more pain. This one, you scrape the wound, right? And the substance that you, or the material that you collect may not be really, how should I say, fine or one layer. You need maybe, you know, to the usual way that we do when we analyze samples under the microscope is we put maybe a drop of liquid, and then we put another thin slide glass on top of it, and then either you press it to remove any air bubbles, and then only you look under the microscope. So that kind of a conventional way of how we do and what do you call to view samples that we take from scrapings under microscope. So yeah, that's a advantage and disadvantage of cellophane tape and also other methods of analyzing skin sampling. So you can do what you call tape sampling, or you can do scraping. Okay, and the thing is that what we also noticed in this issue is that where do you sample? So some of the patients that present with jellyfish sting in the acute state, they will have a lot of inflammation or even rashes coming up onto the skin, and may not represent the area where the actual stinger is actually attached to the skin. So they tend to sample the rash rather than sampling the actual tentacle contact to the skin. So that's why they will not find any nematocysts on that slide or sampling. So area of where you sample the skin is important. Okay, so make sure that you identify. Sometimes these areas are not well visible because of the inflammation at the time, so it's all red. But a box jellyfish sting, normally there will be some area of early necrotic tissue on top of that contact of the skin. Okay, so you can actually you have to look carefully where it is. Sometimes the area is very small, but it triggers a kind of a hyperinflammatory process, dermatitis contact type of feature. For example, those already previously sensitized to jellyfish sting. So it's difficult too. So that's why the healthcare providers, professionals, you know, through some training, a bit of minimal training, simple training, can actually enhance their capability to do a proper sampling. Okay, so just bear that in mind where you sample.
Thank you, Prof. Khaldun. Yeah, sampling techniques is important when we are going to take the samples for nematocytes. A follow-up question on that will be by one of our participants. Could we differentiate different species, Chironex versus other jellyfish, from the cellophane tape sampling of the patient's skins? Yeah.
Prof. Likwanan, I think, is, and also Prof. Sataria have a lot of experience on this, I think, maybe. Different jellyfish, do they have different nematocysts? The nematocysts look different.
Honestly, I am not the expert about nematocysts by sticky technique. So, but I have heard that different species can have different nematocysts. So from the sticky tape techniques, you can know that what is the species, but maybe did not definitely know that definite species, but you can know, and I think that is helpful. So from our protocol, I recommend the doctor to do that also, but it's not popular yet. I think that not commonly performed by the doctor. So in Thailand, we use the history and physical exam and the basic lab for the clinical effects to diagnose the jellyfish envenomation. And sticky technique we try to promote, but it's not very popular now. And I totally agree that it might be the technique that is helpful to differentiate the species of the jellyfish.
Thank you, Prof. Satria.
Thank you.
Prof, yeah, your opinion on this?
As far as I know, we need to collect those samples to confirm if the envenomation is because of jellyfish. But because there are undescribed species in this part of the world, and because related organisms have different kinds of nematocysts even within a species, then I think the finding of a nematocyst will confirm it's a jellyfish sting, but whether it tells you which species is involved, I think you need a bigger sample. About for DNA barcodes, you need a sample of the animal itself about the size of a fingernail. So it will help, but I don't think you can work this to the species level, especially since we have unknown species.
Thank you, Prof. Wilfredo.
Yeah, can I add on to that?
Yes,
Is it
yes,
okay?
Prof.
Yeah, so that's why it is important for us to work very closely with our marine biologists. And we are actually in Southeast Asia, we are working together with what we call Westpac efforts. And we are actually looking at the whole region's species of jellyfish, possible species, and particularly harmful jellyfish. Harmful means that those which can cause tremendous effect on humans if contact, or even our, for example, power plant and so on, yeah, that can cause affect our human life. But in terms of the species, that's why, as Prof. Wilfredo was saying, we need more samples, meaning not sample from the skin, but sample from the water. And this needs to be done by routine collection of this of the jellyfish, proper identification of the species itself. Most likely we will find many new species which are not documented yet. That is another exciting area where we do research. So many things to discover, and I'm very excited in this area because we are facing a lot of problems in the clinical, but we have no idea what they are. So this kind of helps in terms of what we find clinically to help our biologists to see possibly we are actually identifying a new species of jellyfish, right? So that's why it's clinical documentation must be, must be add on with an open mind that nothing is actually yet fully in black and white. So what is found in Australia, in probably US or some other parts, may not be the same as what we find here. So clinical documentation should not be, how should I say, put into a box of what is already known. You should document what you find and then try to get that verified with the physical evidence. And that's where we look at our marine biologists, our friends, to go and dive and as probably the nice nets, to go and collect, not just go walking on the beach. No, there's a scientific way of, as what we explained just now explained by Prof. Wilfredo, scientific method of sampling of the species of the jellyfish for identification. And from there, to answer, I think, Prof. Rizman's question about can we identify? Yes, most likely when we do the sampling, not just to identify the species, but we do sample also the nematocysts or on the tentacles itself, what you call in the very nice environment, not discharged, and probably those which are already discharged. What are the types of different types of nematocysts present on that tentacle? So it's not just one feature, because there are many tentacles that have different functions, right? I mean, the nematocysts with different function. Some nematocysts are discharged just for anchoring. So they are just to anchor, but there are some nematocysts discharged with venom. So these are different functions, and therefore they may look differently under the microscope. So that's why sampling from an organism itself is nice to be put in what we call an atlas. So we are actually trying to do this through CMAX and also through our collaborative work with Westpac. Maybe come up with another publication work later where we have a good reference or atlas of different species that we find. What are the differentiate what you call the features for the species, including what the nematocyst looks like for that species, and then we can actually probably bring in the pictures of discharged nematocysts sampled from the skin features of those who are stung by that jellyfish. So that will become a nice reference, I think, for the region. So yeah, that's a long-winded answer to the question, but I hope it helps us, come into the perspective that this is a very interesting area to work in at the moment in our region. Yes.
Excuse me, can I add on a little bit? Yes,
Sure,
I totally agree with Professor Wilfredo that the nematocyst cannot, if the definite species, it can tell only like the class of the species, like it is Physalia or it is Chilonic, or that's all, and it helps to guide management at the first in ER or in the hospital, only like in the first hour. So in our protocol, we still recommend the doctor to send the whole tentacle, if they can collect it, to our lab also to investigate for the species, for the DNA. Yeah, and I totally agree with Professor Pedro. Yeah, thank you.
All right, thank you, dear speakers. We get to our next question. For all jellyfish stings, when do we decide whether to apply hot water immersion or cold pack, as most of us are not trained to identify the species? I address this question to Prof. Satria.
Hot water immersion for jellyfish envenomation or sting. Is this right? They asked about that.
Yes,
Yeah,
the question is about hot water or cold pack. Yeah.
Or cold pack. So because in Thailand we have our expert protocol that we try to have the group to create the protocol, and now from the consensus from our expert, they don't recommend for hot water immersions or cold pack now for the first aid treatment for jellyfish. But in my opinion, cold pack, I remember that there was one study that cold or ice might aggravate the nematocyst discharge. But for hot water immersions, for myself, my opinion, sometimes I use hot water immersion for pain relief in some patients that I know that it is like the jellyfish that is not like very harmful. Sometimes I use it, especially for the patients that have severe pain. sometimes I use, but it is not included in our protocol now. Some experts still believe that it might aggravate or increase the nematocyte discharge. Yeah, but I agree that there are more evidence or increasing of evidence for hot water immersions, but it's not included. Yeah, but I hope that if we have more information or evidence-based or study, hot water immersions might be included in the future. Thank you.
Maybe Dr. Zainal wants to add on our experience on hot water immersion or hot water or heat therapy.
We don't have much me myself, I don't have much experience on giving hot water immersion for jellyfish. So I because we already recommend to give vinegar instead of others. By your immerse patient to the hot water means you immerse with other substance other than vinegar, in which it may trigger as well. So for me, I don't have experience on that.
Prof. Dikonan, you want to add on a bit about this hot water with or jellyfish thing, or hot or cold pack? When do you apply?
Well, again, with the caveat that I'm a marine biologist, I read some I read a report that the hot water also makes the nematocyst discharge, but I suppose it's the temperature that depends that determines whether it discharges or is neutralized. I should add that I've had experience with fire coral that has been soaked overnight in fresh water, and it still stung me in the morning.
Okay. All right. So just to give a bit of a perspective on the issue of this treatment, hot water or hot or heat or cold. The issue is when we are responding to it, there are two things that we are trying to achieve, right? In the pre-hospital setting, one is to make sure that the whatever remaining nematocysts doesn't cause more harm, and second is about the pain, right? So as we heard just now, the most cases for box jellyfish, is the immediate, very severe pain. So patient, if you apply vinegar, for example, can actually trigger more pain because of the skin exposure, right? So that's one of the disadvantage of vinegar as well. But what vinegar wants to do is not to control pain, okay? It's just for further safety of patient and others. But for the pain, once you have already deactivated the vinegar with vinegar, then you can actually apply whatever you want to apply. Now, that includes either heat or cold. These are just about pain modulation, pain control, prior to or en route to arrival to hospital, right? So obviously, layman doesn't have morphine with them at the beach. These are provided by pre-hospital care providers. But if they are brought by lay people, what can lay people do? So there is a recent study, hot water is already quite established. It can actually reduce pain, particularly for those stingers from cold water region. For example, or also for Physalia, the blue bottle. But not really. The study from Australia is talking about possible chironecs as well from heat application. Heat application doesn't have to be hot water immersion. So heat application can be just from hot pads. You put hot water in a bottle and then apply, or a hot towel, for example, onto the area. It can minimize pain. We don't think that it is directly involved with the so-called denaturization of the venom, but we believe also it's about pain modulation itself, how pain is transmitted from an injured area. So that kind of heat masks the pain from the injury of the venom. But other than that, besides hot or heat application is cold. So there's a lot of study, kind of a limited study also in Brazil, South Africa, South America, that shows application of cold, whether ice or cold pack, also can minimize pain, but they did not do study on Coronac species, but other species. So it says there's no difference between whether you apply hot or you apply cold, both can be done. So the issue is that which one is more available to the masses on the beach? Do you bring hot water to the beach or you bring ice water to the beach? In our situation, most of the time we have cold water available, or our Coke is submerged in ice, isn't it, on the beach? So the Coke can is already cold. We don't find hot Coke on the beach. So that's a different story. You get high from that high Coke, but hot Coke. But the thing is that we are in a warm region, and in our beach is tropical beaches. We have more easily available to us is cold, right? Cold materials. So we can't find any body with standing by with kettle or hot water to boil. We take some time as well. So those are not practical. So we just grab something cold, apply on the patient after applying vinegar, and on the way to the hospital or the medical center. So I foresee, if the studies, that the current evidence showing no difference between hot or cold to control pain after just for pain control, then what is going to be the determining factor is the availability of this stuff, hot or cold, on site. So I think that will become the, which one will you grab easily, and most likely cold is less chance for you to cause more harm, whereas hot water you can have injury of scalding. You don't know what temperature is the water, right? And that can actually cause more harm rather than using cold packs, for example, just to control pain. It is not pouring over unvinegarized wound after stain. So this is after that process of vinegarization. Is actually just for pain relief prior to arrival to hospital. And since we are medical practitioners, when do we say what is our target to reduce pain before arrival to hospital? The question is, doesn't matter. The answer is, it doesn't matter, because in terms of pain reduction, 1.5 to the pain score is sufficiently well appreciated by a person in pain. So let's say the pain is 8, but you reduce to 7.5, reduce to 6.5, the patient will feel more comfortable after that. So it's not achieving zero pain. That is not what the discussion is. It's not practical. Okay, so so some people say we have to control the pain so that the patient, when arrived to hospital, no pain at all, he can smile. No, that's not. It's just not practical in that sense. So in the hospital setting or pre-hospital care setting with professionals, then we have other options of actually controlling pain. Okay, so yeah, so I hope that answers the question as well, to help clarify the questions earlier.
Yes, thank you, Prof. Kalden. I think it answered very well the question. We'll go on to our next question. How do you confirm the Irukandji syndrome based on the Langkawi paper, since the original Irukandji species, the Carupe barnesi, is only available in Australia? I believe this was mentioned in Dr. Zainal's lecture. Dr. Zainal, would you take the question?
I think this is Dr. Aida's lecture. I don't talk about it. Probably Prof. Khaldun is better person to answer that.
Yeah, I mean, that study, that's very interesting because that study was very old. That was one of the earliest study in Langkawi. And from our study also in Manjung area, which is off Pangko Island and Langkawi, we look at a case, patient's file. So all patient jellyfish, so-called jellyfish sting, their file we look at, and most of them were documented as either Irukandji syndrome or Irukandji-like syndrome. So we have no evidence to suggest that. One thing is correct to say that Irukandji Irukandji syndrome was first described in Australia, and it's classically related to the Carukia barnensi box jellyfish. Okay, the 4-tentacle box jellyfish. So or Caribdi. But since then, there are they noted also the same symptoms or similar symptoms, closely related syndromes occurring from stings by other jellyfish as well. That includes, like, for example, Morbacca species or Tamoya species. So these are all 4-tentacle box jellyfish as well. And I believe it's not just limited to this Caribdid species. So because we probably identified similar symptoms also from various other species, non-box jellyfish as well. So which are not well described and well proven yet, but I believe it's not just limited to that. And therefore, what should we classify them if it is closely related to the syndrome of Irukandji? Yeah. So then it should be classified as what we call as Irukandji-like, rather than jumping into Irukandji, because we don't have a Carukia barnensi in our waters in Malaysia, for example. I'm not sure about Philippines. Maybe you are closer to Australia. Maybe you do get some Carukia in the south of Philippines. But in Malaysia, so far, we have never encountered Carukia barnensi. I'm not sure about Thailand. I think Thailand also doesn't have Carukia barnensi. But we have other 4-tentacle box jellyfish, okay? The bigger ones, like the Tamoya, the Morbacca, and various others. So therefore, if there is a syndrome, because this is a syndrome, okay, you look at the clinical findings, signs and symptoms as the development, you have to be closely so-called following the signs and symptoms of Carukia barnensi envenoming to suggest that it is like Irukandji-like syndrome. And I think from the study that was done in Langkawi and the cases, they are not well documented. And therefore, the claims that these are Irukandji or Irukandji-like syndrome is actually misleading and most likely is misappropriately diagnosed. And we know as well, for example, recently we had a death of a French child in Pangko Island, which has never been documented to have box jellyfish. Of the multi-tentacle box jellyfish that can cause death, they always document as just Irukandji or Irukandji-like syndrome. So most likely, I think it was due to misinterpretation of the syndrome that is presented. Whereas most likely they are also caused by multi-tentacle box jellyfish. Okay, which as Prof. Likonan said, we still need to look at get the hard evidence from the sea to confirm this. Yeah, but we know we have a lot of other multi-tentacle and also 4-tentacle box jellyfish along the coast from Langkawi, Penang to Pangko. Okay, so we have already documented that, but we still need to do further surveillance for other species as well. Okay, so that's why I think each case that you get, it's best to consult our experts, clinical experts, clinicians, for example, REX, for us to actually to document well in terms of diagnosis, and not giving, like, say, for example, in the end you want to look at your data, and then your data diagnosed as Irukandji syndrome, but then it kind of conflict to the actual situation. So we don't want you to publish something which is in the end will be, if it got published, it may look not intelligent. Yeah. Okay.
All right.
If I may add,
Yes, Prof.
in one of our monitoring locations, we found a second species, and we don't know what it is. There's a 4-tentacle box jellyfish that was first discovered nearby, just across the channel in the 1920s. But that one is generally harmless. But I wanted to point out two things. When that species was first discovered, Copula civicis used to be a Caribdia. They thought it was just local to the Philippines, but it turns out it's found globally. It's found in Australia. It's found everywhere. There's also a paper talking about different jellyfish, not box jellyfish, but the projections show that with climate change, the range of distribution of those jellyfishes will expand. So I pointed out those two pieces of information just to emphasize what was stated, that there's a lot of jellyfish out there, and some of them are not known to science. And you also have to consider the possibility, given our findings with the ecology, that the people might be stung by more than one species. And now you have this complication of trying to treat something that's actually a combination of maybe more than one kind of venom.
All right. Thank you, Prof. Prof. Satya, you have
Okay, thank you.
anything to add on?
Can I add on about in Thailand? We don't. I think that from the ecology data, now we don't have Carukia benesi for Ilukanji syndrome. So most now that we think single tentacle or 4-tentacle jellyfish that cause harm to our patients are Morbacca that cause Ilukanji-like syndrome, like Professor Ahmad talk about. So I agree that maybe it's not Ilukanji syndrome. It should be Ilukanji-like syndrome. It should be called like that because indeed Ilukanji syndrome should be from only like Carukia benesi. But now if the patient has the local effect, not the step ladder pattern or frontal ladder pattern, but we see there's the tentacle mark, and the patient had like the syndrome of catecholamine surge, like high blood pressure or palpitations, tachycardia, and low EF or cardiovascular effects. Maybe we will think about Ilukanji-like syndrome from Morbacca, and I think that our colleague, Professor Lakhana, published the data about Ilukanji-like syndrome from Morbacca in Thailand also. Yeah, thank you.
Yeah, that's the point that I was trying to make. Sometimes what we did was we put into the box of Ilukanji-like, but the presentation doesn't look like an Ilukanji at all, or Ilukanji-like at all. So that kind of a feature of very clear marking and so on, those are not feature of Ilukanji. So why are we associating it with Ilukanji-like? So rather than doing that, as I pointed out earlier, and this is to probably answer, highlight what Prof. Likwanan mentioned, that we are actually discovering new signs and symptoms. So why are we calling it Ilukanji-like? Just because we want to associate the part of the finding, not all the findings, to Ilukanji. So we should maybe call it a Morbacca syndrome, right? Which are maybe more distinguished to Morbacca rather than really closer to Ilukanji, especially in the immediate pain. By right, it should not be an immediate pain at the local area, and the pain is not at the local area. The skin should not be well marked by the tentacles. Those are not feature of Ilukanji. So if you can't find that in Morbacca just because of the so-called effect of catecholamine surge, which is, I said just now, may not be just from Ilukanji it is actually can be from other jellyfish as well. So it's not saying catecholamine storm only Irukandji. That is not correct. So that's what I was trying to say from our own findings in around Penang. For example, we had cases, those with features of catecholamine storm, but we don't think that it is actually from Irukandji. So as an typical Irukandji. So we cannot associate that finding of that envenoming to become Irukandji-like. So it is kind of a new set of signs and symptoms that we should actually take up to actually explain with finding from the sea. Most likely we find also, I believe, because the amount of the number of the volume of jellyfish around Penang is mostly Chrysaora chinensis. So we think that Chrysaora also may actually have a triggering factor in the venom to cause catecholamine storm. Okay, on top of that, they could also cause vasoconstriction that may affect the blood pressure. And also distal cyanosis, blood flow to the distal digits, causing poor blood flow from that vasoconstriction. So these are just clinical findings that we have ascertained that doesn't really fit to Irukandji. Therefore, we should not be calling it Irukandji-like, because we just don't have the physical evidence from the sea to suggest that this is either four tentacle or non-four tentacle or which species. It is nice that if Prof. Lee Kuan Nan can find volunteers to test out the samples that he found in the sea and to see how the clinical effect is to document, then that would be an ideal kind of a control environment to do the study. But obviously, it's not possible. So what we can do is probably just identify the species, what we can find the toxins in the lab, and we extrapolate to the possible signs and symptoms, right, to human. And again, testing, as you know, testing of toxin to other animals may not appear the same as to human. This is another complication that we see in doing research. So what we find in clinical finding is important is to document each science according to time as it develops, so that maybe from the limited sampling that we have, that's why we are really promoting skin sampling now for the nematocysts for our future research, to go back and look at, and maybe once our marine biologists have all the nice what we call atlas, then we can compare again and see, and maybe we can latch on together, find the actual culprit for that particular envenoming. Yeah, so again, that is what I was trying to say. We have to be more open to new discoveries in our region, rather than Irukandji is just a catecholamine storm only Irukandji. That should not be, I think, in our thinking. I believe, as academician especially. Yeah.
Thank you very much, Dr. Kao. I totally agree with you that maybe we need more study and evidence. And I agree that maybe some expert will think like the same, like single tentacle or four tentacle, and it's called the same, like similar clinical presentations. They conclude that it is Irukandji-like, but indeed it might be Mobaka syndrome, like you mentioned. So I totally agree that we should collaborate for more information, for more study. Yeah, that's very true. Thank you.
All right, thank you. We'll go on for two more questions. So one question by the participants was, Chironex has a distinctive scarring on skin, which helps ID. What about other jellyfish? Usually there appears as reddish rashes. How do we further identify the type of species of jellyfish? Prof. Satria, would you like to answer the question?
Excuse me, can you repeat it again?
The question is about, is there any other distinctive scarring on the skin to differentiate different type of jellyfish stings? For example, if Chironex species, it's a very distinctive scar which we can determine. How about other jellyfish types?
I think that everyone know that if it is like frothed ladder pattern, it should be multi-tentacle, and for single tentacle or four tentacle jellyfish, the skin lesions, I think that is not is like one tentacle, but there is the frothed the picture of frothed ladder, but not many tentacle in my opinion and my experience. But for Physalia species like Portuguese man of war, some mentions about sting or pearl lesions on the skin. So I think it might help some, but I'm not sure like for Cyphosua, it's quite difficult to it identify. But sometimes when we see lesions that is very very painful and erythematous lash like that, sometimes we thought about like Cyphosua or Cyphosua species, but have to ask Professor Wilfredo and Professor Carl about this, your experience about skin lesion. But for me, I think frothed ladder pattern for multi-tentacle and for single tentacle, sometimes it's like frothed ladder, but it's the patient has only like one or two tentacle. It's not many tentacle on the skin, and sting or pearl for Physalia species. And for Cyphosua, maybe the non-specific skin lesions for me and very painful like that. Thank you.
Prof. Wilfredo, your experience of getting stung, maybe?
Like I said earlier, we're still struggling with how many species are involved, and so whatever I say next is based on a lot of speculation. In addition to the fact that the individuals may have come into contact with several tentacles, not just one, you also have to consider that the tentacle width varies if you got stung near the bell or you got the far end of the tentacles, which usually breaks off and will sting you even if it's not associated with the jellyfish itself. So I think there's just too many variables for us to make that connection about the pattern of the lesions and the species involved.
All right. Thank you, Prof. Wilfredo. Prof. Calden, you want to add anything?
Yeah, just to add that that kind of adds more reason for us to do the skin sampling as well. So not just sample from one area, but many areas of the lesion, and that's why we try not to manipulate the lesion before arrival to hospital for us to do the sampling. So application of all kinds of things, including gels and whatever, may impede the sampling method of the nematocyst in the affected area. Okay, so that's why we just say spray. On top of that, there's a new light in the finding that lignocaine spray, lignocaine can actually do both things. One, it prevent the further triggering of the nematocyst, and also, of course, it's a lignocaine, it's an analgesia, so it can actually minimize pain as well. So you get two things in one. Therefore, obviously, it is good, but we cannot say this to the public because it is more expensive and it can have other issues medically. Therefore, we don't really recommend this to the general public. But if it's a pre-hospital care service that goes out to rescue, then perhaps, or even the trained first aiders on the beach, they may be given a lignocaine spray as part of their regimen for treating jellyfish sting first aid. Okay, so yeah, so I have to be careful on what I say here, because people may say, oh, now we have to bring lignocaine spray to the beach also. So yeah, it's not that. Okay, so it's just about how we apply the knowledge that we have based on the practicality of how it is applied by the public as well in pre-hospital care. But in hospital, we are actually now using lignocaine spray. Those who doesn't have a spray, after sampling, we apply lignocaine gel over the stung area. And that helps the patient quite significantly also in terms of pain control, besides the opiates that we give the patient in the hospitals. Okay, have a look at the literature. There are a lot of now finding about lignocaine and how it helps in jellyfish sting. Okay.
Thank you. There's this question by one of our participants. Other than the sellotape sampling, can we also do swabs instead, which can be done for PCR testing to genetically ID the jellyfish?
You will not get it immediately. That's one of the things. And yeah, and you're doing kind of what protein testing, and also trying to get a DNA testing with the swab. Is that what you are suggesting?
Yeah, that was the question asked, whether you took sampling by a swab method instead of a cellophane tape method.
Yeah, well, maybe Prof. Wilfredo can answer that. Lab testing for these specimens.
Sorry, not.
Okay, the question was whether we do swab testing for PCR instead to determine the type of to ID the jellyfish. Is this can it be done?
I don't think so. Like I said earlier, what's generally known, what we use as the standard for identifying, in addition to morphology, would be DNA barcodes, and as far as I know, at least for the extraction procedure that we followed, we needed a sample that's about the size of a fingernail, and so I think a smaller sample will not yield enough genetic material for the identification.
Yeah, I know where the angle of this question comes from, or probably from the sampling of snake venom and snake venom test kits in Australia. So at the moment, no, we don't have that kind of testing or bedside testing that we can do just from sampling from the wound. Okay, yeah.
Okay, we'll get to our final questions for today. Just curious as to why it is not recommended to apply elastic bandage on areas affected by jellyfish sting. Yeah, anyone would like to answer that?
Maybe Dr. Zainal, any angle about pressure bandaging immobilization for marine stings?
I think number one, if you look at the wound of the jellyfish sting, the area it might we can see is like a burn area, and then in which if you apply, there's a possibility of means pressuring on the area, like a burn area with pressure. It doesn't looks good for that type of wound. And number two is the elastic bandage. I think it's more of we applied for snake bites, and then or even some unidentified bite that in which the wound we don't see much, and then it doesn't progress into swelling of the wound, then probably that one is better rather than for this type of for the jellyfish, we don't recommend on that.
Thank you, Dr. Zainal. Anyone would like to add anything on regarding the topic on applying elastic bandage on areas affected by jellyfish stings?
Yeah, I agree with Dr. Zainal. There are clear indications when to use elastic bandage, or what we call pressure bandaging immobilization. That kind of from the angle of snake bite, we have snakes in the sea as well, and sea snakes fit this criteria of indication to use PBI. So therefore, sea snake envenoming most likely occur in fishermen, and they are sometimes way out in the sea. Takes time for them to come to shore to go to the hospital, and therefore applying pressure bandaging immobilization for this patient may actually help buy time for them to reach the hospital. So that's one. And then the thing is that you have to understand what pressure bandaging does. So it's actually just to impede our lymphatic drainage, right? So most of the time, as Prof. Wilfredo said, the jellyfish sting, envenoming the stingers are actually already delivering the venom in the body. It's very fast, and sometimes this venom is very transient as well. Okay, and the location of the sting is actually really in the lymphatics, but we see that some of them actually why very short nematosis can cause very quick what do you call sign symptoms, systemic sign symptom, cardiorespiratory arrest, for example, is much faster than a bite from a snake. So why does this happen? What's the difference? So it depends. If you look closer at the stinger, it just not just penetrate one. So there are studies showing that it actually just penetrates through the skin and it expands laterally as well. So there are multiple tubules going laterally, and this crushes or penetrates the capillaries. So the capillaries are the one that then deliver the venom very fast into the circulation, venous circulation back to the heart, and systemic envenomation occur. Therefore, the patient, that's what it calls what we call pore-forming venoms or toxins that cause this cardiovascular envenomation. Okay, so that's already happening, and then you're trying to apply pressure bandaging for the things that is already spread in the capillaries. So pressure bandaging is involved with lymphatic spread rather than a blood vessel spread. So capillaries is higher than pressure in the capillaries, a bit higher than the lymphatic, I think, or is it the same? So it doesn't really add on to the process of managing the patient. Okay, it just maybe wasting more time, perhaps. Okay, yeah. So that's why it's a consensus saying that doesn't make any additional benefit to apply PBI for jellyfish sting patients. I hope that answers.
Yes, thank you, Prof. Khaldun. Okay, we'll just put in
Shall
a
we ask that question in our master's exam? Maybe we should, Dr. Zainal. We'll see.
Okay, one final question. We'll just take one last one from one of our participants. Hi, good morning. May I know if it's a stingray sting of unknown species, no picture of the stingray, which zone do we triage them to? In Malaysia setting, Dr. Zainal, would you like to go about how to go about if stingray stings?
Okay. For us, the decision to triage the patient to which zone is actually not depends on the species, but it depends on the clinical manifestation and the need for urgent treatment. So it doesn't matter what species it is. Then if patient is has a life-threatening condition, And then you have to go to red zone. If non-life threatening but patient require urgent treatment, then go to yellow. If patient, if you don't, if you are uncertain whether this what species, in which you think that there's a potential that this species is a venomous or non-venomous, then just go to yellow zone. That's good enough rather than patient waited in a green zone. Thank you.
Thank you, Dr. Zainal. How about in Thailand, Prof. Satria? Any difference of management for stingray stings in Thailand, emergency department over there?
In Thailand, I agree with Professor Sainal that we will encourage the patients to apply the vinegar at the scene and reaching to the hospital as soon as possible for more treatment. And I don't have know anything at all from Dr. Sainal.
All right, thank you, Prof. Satria. I think that comes to the end for our forum for today. I would like to thank Dr. Zainal, Prof. Satria, and Prof. Lichuanen, our advisor, Prof. Khaldun, for being with us today. So we have come to the end of our session today. Thank you for joining us. I would also like to thank our sponsors and collaborators for today, MST, MySort, REC, Asian, CEP, SIG, PRN, PTS, and PCEM. Thank you all for joining us for today. Please join us again for next week for our third week on the Emergency Medicine Seminar Series. It will be on the land organism, envenomation, and poisoning. Our feedback form and the QR code will be shown now after this. Please scan them to get the CPD points and certificates. After filling up the feedback form, the certificates will be issued. Thank you.
Thank you. Thank you very much. Goodbye.
Thank you.
Thank you.
Thank you, Sataria. Thank you, Prof. Thank you, Dr. Zainal.
Thank you.
And thank you, Dr. Aida. Take care.
Thank you, Professor Khaldun.